Hi, this is Joe Snodgrass. I'm here to give a little presentation or make a video on nurse practitioner and MD, um, the groups uh, to try to establish nurse practitioner autonomy. As far as the stakeholders go, we have the groups of MDs, we have the nurse practitioners, we have the patients, the public, the state authorities, and the insurers to some extent. As far as their roles go, the MDs and the nurse practitioners, they're basically the providers who establish services to patients and the public in general, and in turn the insurance companies reimburse the providers for their services that they perform. Like the patients, they receive the services, they pay the providers, maybe a copay. If they don't have insurance, then they pay straight up for the provider services. The state authorities, as far as their role, they go in and they regulate based on each state the authority that the nurse practitioners can have. MDs, they go in pretty much with total autonomy, whereas nurse practitioners have to earn in their authority in various states. Insurers, as far as their role, they pay the MDs, they pay the NPs, the providers, for their services. As far as the educational needs for each group, the providers, like say, the MD needs to learn that the nurse practitioner role is not there to replace them, but more or less as a complement for them. Both the NP and the MD, they both need to educate the patients of different roles in providing services. Patients need to learn roles of the nurse practitioner. How they could be a role in as far as enforcing autonomy and help providing lower costs for them. They could do this simply by just lobbying or writing letters to their state authorities. The insurance, the state authorities, obviously they already know the role of the NP, but they need to understand and accept that the nurse practitioner can provide the same services as the MD in most acute care settings. And it would lower in healthcare cost overall if the state authorities would just provide total autonomy for all nurse practitioners throughout the United States. The insurance, that they need to be educated that provider services are the same in primary care for the most part. I'm sure they already know this. As far as theoretical foundation and conceptual framework underlying my proposed CSP intervention, the way I'd sum it up, the word theory refers to a comprehensive explanation of an important feature of nature that is supported by many facts gathered over a period of time. In other words, it's just basically a theory. It's my theory. My theory is that me, as a nurse practitioner in an acute care setting, can provide the same services as an MD at a lower cost. That's my theory. As far as the conceptual framework goes, it helps the researcher see clearly the main variables and concepts in a given study. It provides the researcher with a methodology, research design, target population, research sample, data collection and analysis. It just guides future research. So, in a nutshell, we're talking conceptual framework and theoretical framework is used interchangeably. It kind of means the same thing, but like I said, the theoretical framework is a theory, my opinion, my theory, that I can do the same as an MD in a certain setting. The conceptual framework is a set of related concepts. You know, if I'm working in, like I just said, and I'll reiterate it again, if I'm working in an acute care setting and I see a patient who's got otitis media, I could prescribe Augmentin just as well as the MD can. Same goes with strep throat. That's a set of concepts. You do a RST on a strep throat, if it comes back positive, you're going to prescribe penicillin. I do that, so with the MD. I do it at a cheaper cost. I don't see where the hang-up is here. It's just all political. The MDs kept yelling safety, 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 but all the literature keeps repeating itself. There is no real safety issues when it comes to NP versus MDs. As far as to plan my intervention, I think my instructional materials, they are going to be designed in a way to stimulate the learner's senses and to simplify complex messages. The simpler the better. Just seal it with a kiss. Just keep it simple. Be creative with instructional material. Add variety for all the audiences. The ultimate goal is to motivate change throughout the country and to provide or ascertain rather total autonomy throughout all 50 states. As far as my plan for delivering the intervention, my biggest tool is going to be the internet. It's going to be mobile, using websites, social media such as Twitter, videos on like YouTube, Facebook, emails, articles, surveys via SurveyMonkey or whatever the case may be, PowerPoint presentations, continuing education, CEUs. Back, I guess, in the early 2000s, mid 2000s, the biggest instructional intervention was basically handouts, books, brochures, leaflets, instructional sheets, things of that nature. The biggest problem, the biggest hang up with those type of things are, I mean, while they're good and people want to sit down and look at those type of things at their leisure, they're very abstract and has no immediate feedback available. So my interventions, like I said, it's going to be like this website here that I just referred you to. It's going to be a lot of things coming on board here. As soon as we get the websites done, we'll do mobile apps for iPhones, and we'll let it go at that. But that's my basic intervention strategy. Got a lot of programming experience. I see no big obstacle in implementing this whole thing, and I think it's going to be very effective throughout the country myself. But anyway, thank you very, very much, Dr. Shine, and I appreciate the opportunity of presenting. Thank you very much.